So today I'm going to be talking to you about lymphocytic hypophysitis. It's lymphocytic because it cells, cyto, which are lymphocytes, and it's going to be infiltrating inflammation-itis in the hypophysis, either the adenohypophysis or the neurohypophysis of the pituitary gland. And so the clinical presentation of this is going to be like any cellular lesion involving the optic chiasm, either optic neuropathies or junctional scotomas like the junctional scotoma or the junctional scotoma trochlear, or the bitemporal hemianopsia, which would be the classic, or even optic tract homonymous hemianopsia. So we can mimic pituitary adenoma, and that is the main consideration in the differential diagnosis. The MRI scan is going to show the cellular mass with supracellular extension compressing the chiasm. The clinical features that suggest that it might be lymphocytic hypophysitis are the acute nature of the inflammatory process in LH, acute with headache, bitemporal hemianopsia, and the radiograph normally shows symmetric and homogeneous enhancement, which is a little bit atypical for pituitary adenoma, which is usually asymmetric, causes stalk deviation, and is inhomogeneous. It's heterogeneous in its enhancement pattern. And if we see the stalk enhancement, that's also a clue that we have an infiltrative process like hypophysitis rather than a compressive lesion like pituitary adenoma. And it often occurs in the setting of pregnancy or postpartum. And so if you've got an acute bitemporal hemianopsia in a pregnant patient, you're going to be worried about pituitary adenoma and pituitary apoplexy. But if we see symmetric and homogeneous enhancement or stalk enhancement, we really should be thinking about lymphocytic hypophysitis. And in that setting, even though a biopsy may be necessary to confirm the diagnosis, steroids are the treatment initially because it's inflammatory. So because lymphocytic hypophysitis might respond to steroids, we're going to give steroids. And we're going to be looking for what else could mimic lymphocytic hypophysitis on an idiopathic basis, because it doesn't have to be lymphocytes, it could be sarcoidosis. Or it could be inflammatory infiltrative disease from IgG4. And that means we're going to be looking elsewhere in the body, CAT scan or PET scan of the chest, looking for hilar lymphadenopathy or other evidence of pulmonary involvement in sarcoid, or IgG4 infiltration in other organ systems, retroperitoneal or other glands, parotid, lacrimal gland. Other glands can be infiltrated with IgG4 disease. And then the infectious and inflammatory conditions also have to be considered in the differential. The usual suspects, we would call that syphilis, ANCA-related disease, all sorts of things that could mimic an infiltrative process at the level of the pituitary gland. So you should be worried about lymphocytic hypophysitis in an acute presentation of a bitemporal hemianopsia in a pregnant lady. You're going to do the MRI scan. If we see symmetric, homogeneous enhancement or stalk involvement, or if they're presenting with diabetes insipidus, that is a very atypical feature of pituitary adenoma. You should be thinking about infiltrative processes. You might have to have a biopsy to confirm the diagnosis. We're going to treat it with steroids, and we're going to work it up for sarcoid, IgG4, and the usual suspects.